In the previous episode, we discussed the indication of CBCT in endodontics, and we thought we could have our guest today to put some theory into practice in order to have a deeper insight about the use of CBCT in clinical endodontics.
I think it's a great idea to apply those indications discussed before. So, ladies and gentlemen, welcome to the 15th episode of Endocast, hosted by Francesca. Hi, Francesca.
Hi Ahmed, and bye Ahmed Shauki. For our topic today, we are happy that Dr. Omar Ikram accepted our invitation for the second time, despite his very busy schedule. And we know that he just finished some lecture among a tour in Australia. And before we start, we need to introduce Dr. Omar, even if most of you already know him. So he was born in New Zealand, then he worked in New Zealand and UK. He got a Master in Clinical Dentistry and MRD at King's College in London. And he is a very skilled clinician, no need to say that, an international educator and co-founder of the EndoPrep app and fellow of the Pierre Fauchard Academy. He is currently practicing at the Specialist Endo Crow's Nest in Sydney's North Shore in Australia. So, welcome again, Omar.
Thanks so much for having me on the podcast. It's great to see you guys again, and I hope you're enjoying the winter where you are.
Well, I know that radiation can be emitted from different objects, and there are different examples to explain such emissions, as well as how much radiation doses emitted in our practice. Can you explain to our colleagues such interesting findings?
Yeah, so I was having a think about this a few months ago when we started talking about CBCT, and I thought to myself, well, I'm a dentist and I wouldn't know what a microsievert looked like. And so if I don't know what a microsievert is, apart from a measurement of radiation, that means that almost no one in the general public who I speak to about radiation dose will actually understand what I'm talking about. So it's better not to think about these things in microsieverts, but to talk to the patient in regards to how many bananas they are getting exposed to. Because a banana is actually zero point 0.1 microsieverts. And if you look at the other note I've got there on the slide, a 5-hour flight from New York to Los Angeles or Perth to Sydney, and I'm about to go to Perth in a few days' time to teach there, is 40 microsieverts. So that's 400 bananas. So if you have that kind of radiation dose from a flight, that gives you some kind of relationship to what we're actually doing for our imaging in dentistry, because now we can sort of start understanding that the level of radiation from a flight is relatively high if we think in regards to what we're going to get out of that with regarding our own imaging when you look at the fact that a radiograph is only 5 microsieverts. So really when a patient gets a dental radiograph, it's very, very small. In fact, it's much lower than that now. There are some papers that put this figure at 1.5 microsieverts with the faster film and the digital technology and the collimation that we now have. So we're seriously looking at really low levels of radiation for digital radiographs in the traditional sense. For CBCT, obviously, we are looking at higher doses, but the information we get from those doses are significantly better. And, to the point where now we don't need to sometimes access a tooth to look and see if it's cracked and things like that. So these are very, very important things that will save the patient time, and also the patient saves a lot of money sometimes with treatments, and also it helps you run your practice more efficiently. So in the long run, these kind of radiation doses are actually completely okay. In fact, I did have a look up online before this talk, and 1 sievert dose is a very high level, and that's considered to be a serious level of radiation at 1 dose, which would be equivalent to 1 million microsieverts. So again, it's a bit like if we look at radiation as a toxin, and if you have a very, 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 very small amount of that, but you have it like infrequently, it's completely fine. And so I suppose the best way you can describe it to some people, it's a bit like, I guess, smoking or maybe drinking alcohol. You don't have a whole lot at once. You have a little thing and then maybe a cigarette every month. I mean, it's not going to be a harmful thing, but if you have it regularly, then it will eventually, obviously, over time be harmful. So, and radiation itself is also something that we get from background background behavior, and also we get radiation from the sun, etc. So it's not like they have no radiation and then they have a radiograph and then they have radiation or a CBCT. They're getting radiation all the time from normal behavior. So it's important for patients to understand that everyday activities involve radiation. It's nothing to be afraid of, and the dose that actually causes harm is extremely high. So that puts things into perspective, and I feel that radiation now is a big talking point in our profession, because before it was sort of we try and do as little as possible, but now we know that radiation isn't quite as harmful as we thought it was, and the benefits are huge for the patient if we can get better information and treat them more efficiently and also save their time. So it's actually a really, really good talking point. And let's be fair, if we didn't have any discussion about radiation with regarding CBCT would be taken on every patient. That's the only thing, because it gives you all the information. So what would you rather have, 2D and sort of some information, or 3D and all of the information? We'd rather have 3D and all the information. So the only thing we're talking about is a radiation dose. And if that radiation dose is insignificant, as I'm describing, then why not scan almost every patient?
Makes a very good point, and that's quite interesting. Also, the way in which you can present to the patient the amount of radiation comparing to something that they really know. I think it's very easier for you in the communication process to make them understand what they are going through. So it's very nice. But when it comes to CBCT, we hear a lot of terms when we talk about the parameters, and so we know like the voxel size, field of view, and resolution, etc. How can these all be related, and how all this value, what do they tell us?
Yeah, so that's a good question, Francesca. The field of view size is basically how many how big the amount of area that we're scanning. So 5 by 5, we're looking at basically 5 centimeters by 5 centimeters, and so that's obviously a small area of someone's mouth. Then you go up in sizes. You get to the bigger sizes, so you're talking about upper and lower arches and things like this. In endo, generally, all of my views will be 5 by 5. And then you're talking about the resolution after that. So in endo we want small field of view because we're looking at 1 or 2 teeth. That means you can scan a very small area of the patient, but you can increase the radiation dose for that very small area. So that will then give you a better resolution. So what this does is then decrease the voxel sizes. So a voxel is basically similar to if you do a lot of computer games, you will have heard of the term pixel. A voxel is just a 3D measurement of a pixel. It's called a voxel, and so as you can imagine, if you remember the video games back in the 1980s, the Space Invaders, they have huge pixels and they look really misshapen. That's what happens when you have large pixels, or if it was 3D, it would be large voxels. So basically, as you decrease or as you increase the quality of the image, you decrease the voxel sizes. And so that's basically what you're doing. You're creating a situation where you've got a small field of view. So you have a very small area. You don't need to irradiate a large area, and then you're basically going to increase the resolution. So the settings, the low, standard, high, and endo resolution are just a setting on the machine that you set, and it's basically going to choose the voxel size appropriate for that resolution. So obviously endo has the best resolution. I have to say I generally take high resolution but not endo resolution images because I'm able to work things out without having to take endo. But for some patients, I'll be taking endo resolution if I'm really looking at some sort of tiny bit of the anatomy, which is so that the more anatomy you need to want to see, the higher the resolution you need to have. So endo being the highest. You can see on the graph there is no endo resolution above 5 by 5 because the radiation is deemed by the manufacturer to be too high if you go in higher settings. So endo generally just the 5 by 5 setting. So that's basically a rundown of what that chart explains. And this is a similar kind of chart. It does tell you that basically you've got 4 microsieverts. That's the interesting one here, is that the machine is for a small 5 by 5 mini dose setting. It's basically the same as what a bite wing used to be in the 90s. I described 5 microsieverts on the previous slide, and so it's 4 microsieverts for a mini dose. And so this means that now we have a machine that will show us 3D technology or 3D imaging, but like at the same dose as a bite wing used to be. The other thing that this then raises the point is that what do we use this mini dose setting for? And the answer is it's a very, very useful one for younger patients. Because often when we're treating younger patients, we're not looking at the root canal anatomy so much. We're more looking at anterior teeth trauma, whether the canines are impacted, whether they're impacted buccally or palatally and things like that. And so a mini dose is very applicable for these kind of patients. As patients get older and their absorption of radiation decreases, you can then go up to the higher doses. So I tend to scan, if I'm going to scan a patient who's young, I will be using mini dose settings and trying to stick to really, really low radiation doses. Other than that, I'm happy to use the higher doses of the machine. As I said, I don't go as high as endo generally. And you can see that the small 5x5 high resolution is about 32 microsieverts, 42 microsieverts. So we're talking about 9 to 10 times a bite wing used to be back in the previous slide, as I mentioned. So as I mentioned before, there are a few things that we can tell our patients. So patients often say, radiographs, they don't want to have radiographs. And I'll say, look, it's been a big change. I mean, if you look at Ludlow, 5 microsieverts, and now we're talking about 1.5, microsieverts and 15 bananas. So we've gone down from 50 bananas to 15 bananas. And that's 2011, and obviously things have changed since then even. The mini dose is only, as I said, an old bite wing, which was a 4 microsieverts or 5 microsieverts in the previous Ludlow study. That's 40 bananas, and a high resolution, it's about 32 to 42 microsieverts, so 320 or 420 bananas. So basically, the other thing we have to think about is regarding medical chest X-ray, and then this is, I think, where the patients get confused, is that we're talking about dental radiographs, and they're talking about medical, and basically, a medical radiograph of the chest is about 200 microsieverts, which is way, way, way more than we're going to use in dental. Even CBCT scanning is basically going to be way lower than a chest X-ray. So we have to bear this in mind. Patients, what they think about, what they look at, are probably the medical stats rather than the dental ones. So it's important to, again, educate your patient on this radiation dose. And it's so worth it for the extra information, in my opinion.
Well, that's quite interesting, and I think many of our colleagues would like to know more about that and how they would explain to the patients their radiation exposure. When you are doing endo with a lot of X-rays, and when they ask for a CBCT, so the people or the patient get confused about the amount of radiation. So thank you for explaining that so simply. And let me go to the next point. I remember that there was an article in 2017 in Journal of Endodontics discussing the influence of the CBCT on the clinical decision making among specialists, especially in difficult cases, and how they have changed their opinion or decision after seeing the case CBCT. So, can you give us some example on how CBCT can make the clinician decide when to treat, when not to treat, and how to treat, and how it guides about the treatment plan in general?
Well, that's a very good point. You can see here, this is an interesting one. This patient was a 75-year-old male with asymptomatic apical periodontitis, but an apical lesion. Obviously, it's tooth 2.5, or the upper left second premolar. He's got poor oral hygiene, and obviously that needs improvement, root caries. But we're looking at the upper left second premolar. And so I looked at this tooth and I thought, in a patient like this, there's no reason not to scan the patient and work out what's really going on. Obviously, with the 2D radiograph, I do like, there's two reasons for taking a 2D radiograph in my clinic that I can think of that would be a good additional benefit to the CBCT. One is to look at the restorative margin, because a lot of the CBCTs don't show, obviously, they show sections of the restoration, and there's a bit of scatter and things like that. So you tend to get a funny blurriness around the restoration, and sometimes you're not quite sure if there's a crown margin where there's caries, and sometimes you can't quite see. And the other thing is, CBCTs don't tend to show density differences as well as a 2D radiograph. So if there's a fractured instrument in the root canal, then a CBCT is less useful. So that's when 2D radiography becomes something that I'll definitely do as well as the CBCT. But I tend to do one or the other if possible rather than both. But there are times that you should take obviously both to check out the restorative margin. If I have a good radiograph from the dentist and they haven't started root canal treatment already because they could have had a complication during that treatment, then I'm happy to go with just the CBCT and use that. Otherwise, I will take this. But you can see I've taken a pre-op radiograph in this situation. I'm looking at the restorative margin here. I'm trying to work out how bad the caries is because he's got lots of root caries. And you can see it, obviously, there is a deep restoration into the pulp chamber, basically, of the upper left premolar. And if you go to the CBCT image, you see some interesting things where you can see the root is actually resorbed and the apical foramen comes out way before the root apex on the radiograph. So you're going to fill this and you're going to find that you're short on the radiograph, but that's actually the end of the root canal. So if you flick to the next slide, you'll see that I have filled up we're going to start, firstly, the verdict. I was going to talk about that. So first of all, the tooth's restorable. And we want to try and save the tooth. It's got reasonable pericervical dentine. The DO part is the damaged part, and we can fill this with a deep marginal elevation and basically save the tooth. And the patient's 75, so we can easily keep this going for at least 5 to 7 to 10 years or something like this, and this should be sufficient for the patient well into his 80s. So there you go. We filled the tooth, and of course, there's the apex being short of the radiographic apex, and that's an interesting thing to show because we know the reason for that. You can see that the other teeth need restorations in his mouth, so hopefully he got them done straight after I treated this tooth. But basically, you can see that this is not a problem because we were able to see this on the CBCT scan beforehand. But if you hadn't taken the CBCT scan, you may think there's some kind of extension of the root or there's an extra part you haven't cleaned out. You might even think there's another canal that goes to the radiographic apex there, but we know that from the CBCT, there's just that one canal, and it finishes much short of the radiographic apex. And this is good to know. Here's another interesting one. This patient was actually referred for external cervical resorption of the last tooth there, the second molar, and they came in and I looked at the tooth and I thought that there's no symptoms with the second molar, but the first molar has a periapical lesion and is symptomatic, and it had been root filled 12 months earlier. You can see from the radiograph here, there's something interesting that has an occlusal restoration in in the first molar tooth. So what we did is a CBCT scan just to check out the external cervical resorption, which I think is mandatory. I mean, I think I haven't done a root resorption case ever and not taking a CBCT recently. I mean, that would be it's so worthwhile getting that information. So if you go onto the video there, you'll be able to see that you can see there's the resorption defect there, and basically there's a root fracture in the first molar. Can you see the little defect behind the molar there? Basically, that is what's happening. There's a crack all the way through the first molar tooth. So in actual fact, the first molar tooth is really the one that's going to be a problem for this patient, and the second molar is going to be something that obviously needs extraction. We can see how deep the resorption is. It's at the alveolar bone level. So you're going to struggle to put a ferrule around that tooth, which obviously needs to be done because the crown that's on the tooth currently doesn't fit. So it gives you all that information, and all of a sudden you go, "Wow, it's the seven's not restorable. Neither is a six because it's fractured. But the six needs to be addressed first because there's a fracture down the tooth. The seven is asymptomatic currently and could be monitored until it needs extraction, or the patient could go for that. But I talked to some guys about this in the implant business, and they said they would look at replacing the first molar first, stabilizing the occlusion, and then the second molar would be second if they were to do it in that order and want to replace the seven. Okay, so yes, as I mentioned before, the 3.6 and 3.7 extractions, but 3.6 actually has the fracture in it, and we revised replacement of 3.6 because it's fractured, and obviously 2.3.7 later maybe, or basically linked up with some kind of restorative plan. So it's changed our plan from treating the external cervical resorption on the second molar to extracting the first molar tooth. and just changing the plan of what was going to be done. So it really does help you with planning these cases. And now the patient knows why the first molar tooth is a problem. They had slight tenderness and said it had been bothering them occasionally, and that's completely why, because it's fractured. You don't have to open up the tooth or check for the fracture either now.
Thank you, Omar, because it's very informative and very helpful for the everyday clinical activity. And do you think there are some instances when the patient comes with a very old treatment that recently became symptomatic? How can we use the CBCT to assess if we actually have to treat the tooth to give a benefit to the patient, or we should think about maybe extraction and putting an implant?
Yeah, that's a very good point. This is a good clinical situation where this patient was 45 years old. So if I look at this patient's sinus and I think, wow, it's quite pneumatized, and basically an implant's going to be a challenge here. So the patient is 45, so they've got many years to live. So we're going to have to try and hold on to this tooth as long as possible, because an implant, as I've mentioned many times, if you think about how implants work, they place a screw in the bone. There's no periodontal ligament. You lose bone and then eventually lose the implant. It does take a long time, 15 or 20 years, but for some patients, if they're 45, they're going to be dealing with an implant failure in their lifetime. And I always say this to patients. Now I look at my job so differently as an endodontist. I look at my job as a person who wants to plan for the tooth loss as they get older and how that should be staged, because we're dealing with compromised teeth most of the time in endo. We're not dealing with healthy teeth much of the time. We're dealing with these compromised teeth, and we're trying to work out a plan that of treating this patient that will fit into having a fixed option for their tooth for the rest of their life. So, as I mentioned today, I did a post on this. We're planning for this tooth to hopefully last the patient into their 60s and beyond. And if it really does need an implant, which will be extremely difficult here, then that might give you 15 years or so. I mean, it depends if it's possible here. I mean, this patient may need a bridge. Again, if that's the case, they definitely need it longer than that, because once you have a bridge, the abutment teeth are going to have problems in 10 to 15 years, and then they're looking at root canal treatments and then loss of the abutment teeth and obviously the pontic, which will go. So with this kind of patient, it's very, very, very important to look at that tooth and go, look, we have to just try and save this tooth. I mean, he's 45 years old. And basically, the root canal treatment is done 20 years ago, but you can see there's problems with the treatment. It's a bit short. And so I dismantled this entire crown and removed the post, and then we root canal treated it. But before I did that, I did a CBCT. But so I just explained this. Implant's difficult, and basically retaining the tooth is an advantage, because it would reduce the lifespan to have a bridge. And so here's a CBCT, and you can see MB2 hasn't been found. You can see that on the previous radiograph, it showed that the canals were treated short of the apex. You can see there's very little bone to put an implant into. So I root canal retreated the tooth, and placed my own fiber post and core, and then I just left the tooth prepped like that because I couldn't put the crown back on, and the general dentist did actually eventually place a crown on this tooth. Waited for a bit of healing. I think I waited 3 months, and then 4 months after the completion of the treatment, took a radiograph, and you can see there's a bit of bony infill there. It's only early. You'd expect bone starts filling in 3 months or more after the treatment's finished. And you'd expect this to keep going. It goes on, and you're looking at probably 1 to 2 years before the apical lesion heals. But as we know, and it's not always going to fit like that. But at the end of the day, the patient's asymptomatic, and there's some sort of healing going on. So I'm happy for this patient to go ahead and get a crown placed on that tooth, and hopefully he can go well into his 60s with that tooth.
Okay, so now can stop us at the issue of the classic missed anatomy and how we can locate it. So we discussed that in the previous episode from a clinical point of view. So can you tell us about some information about how to locate or look for the missed anatomy, especially the MB2, in viewpoint of the 3D imaging? That's what was my question.
Okay. Yes, that's a really great question. So we're always looking. I often say to dentists, we don't really see a canal definitely all the time on these scans, because, as you know from taking 2D radiographs, a file that's size 10 or less is very difficult to see the tip on a radiograph. And it's the same on a CBCT. I mean, a CBCT is just a 3D radiograph. Um, and so the same for the canal. I mean, it's well documented in papers that if the tip of the instrument is small, that you won't see it as well as some instruments. Obviously, when it gets to a certain size, you'll see it. So the same for canals. So it has to be, if you want to see an actual root canal, the resolution has to be very good. Obviously, that's one point, and the other point is that the canal has to be quite wide. The same for cracks; it has to be quite wide. So if you if you're looking at the mesiobuccal root, or a root that you're looking for another canal, and what you're looking for is asymmetry. So it's that Krasner and Rankow study about the symmetry of the root canals. So we look at basically the asymmetry, and you can see here there's a slight asymmetry, although it's an upper 7 in a first molar position, this tooth. So it's actually you won't see another canal, but you'll see that there is some asymmetry to this, but it'll probably just join up, as you can see in the slice there. It's not going to be, it's not it's not buccally placed. And if it was more buccal, you would say there was a separate MB2 on more palatal, but it looks like it's going to be one of those figure 8 shaped MB2s, which is what it ended up being. But the fact of the matter is that obviously the treatment was a bit short also, so that is missed anatomy in itself. But we are looking for that asymmetry to see if there is another canal present when we treat all these cases. So that's my tip, is to not look for a canal that you can definitely see, but look for, is it symmetrical, is it not symmetrical, is the canal in the middle? And then this one, it's almost in the middle, but there's a slight appearance. There's probably another canal next door to it, very close. But that's how upper 7s often present. They have that thin MB2, or should I say figure 8? I like to call it figure 8. It has that kind of shape where there's an MB1 and 2 like together. So they're almost always join up in upper 7s.
And I have another question for you, another perplexing situation where a patient comes with a cracked tooth. How can we use the CBCT to reach the best clinical decision for that patient? Is there maybe any recommendation for root canal treatment, or maybe extraction is a better option? So how can we decide?
So this is a good one, because in this patient you can sort of see that they've obviously got a big fracture in their tooth, and then it comes down to is the fracture involving the bone? So there's a few things I look at here. So first of all, number one, the tooth is minimally restored, and it's cracked. So that's a bad thing, because there's very little weakening of that tooth for it to crack. So if you have a restoration in the tooth, what I tend to find is it cracks on one side but not straight through the tooth. That's just a general finding I have. But you can see this is minimal restored, and it's got a cracked line mesial to distal. So the next thing we look at is what I do is I vitality test this tooth and say, look, is the tooth vital? Because if the tooth is vital, there's a high chance the crack is just into the pulp or close to. And obviously, the Sharif and Davis paper shows that vital teeth with cracks have a better outcome than necrotic cases. So this is one thing that I do as well. And if the tooth in the pulp is necrotic, then I start to get more concerned. Next thing I'll do is a scan, because that'll show us areas that involve the bone. Because what happens is, as the bacteria from the crack infiltrate the pulp, they also the crack will actually allow the bacterial toxins out the side of the root and into the periodontal tissues, and they'll bring up a periodontal cavity or a periodontal defect. The problem is, when you try and probe the patient, you can't probe in the mesial and distal regions of this patient easily. That's obviously uncomfortable. And even if you've got a pocket of 3 to 4 millimeters, you wouldn't necessarily suspect a crack, the patient is in their 70s and they might have some periodontal disease. It's a really difficult decision to make. You certainly wouldn't, unless the crack was very isolated and deeper than that, you would probably try to investigate this. But with a CBCT scan, you can see there's these V defects in the bone. So what I do is I scroll on the axial, and then I scroll in the sagittal views. And so what I'll do is I'll scroll on the axial first. As you saw in the previous case with the first molar, the lower first molar, there's a little bite out of the area. It's a little defect in the bone adjacent where the crack will be. It's like a U shape. And so when you get that, you locate that with the software, and you go to the sagittal view, and it'll show the bone's good, and then it'll show in two slices there's a V defect, as you can see on the right hand side here with the V. There's a V defect in the bone, so you know that the crack now involves the alveolar bone, and unfortunately, it's one of those teeth we have to say to the patient, we're going to have this tooth removed. Probably, I never say 100%, because you never know the situation of the patient. Maybe the patient has a poor prognosis themselves and just wants to get this tooth treated, and then not worry about the periodontal problems that are going to occur. But like, it's highly likely with a tooth like this, it's not restorable. But an opinion on this is really important, because again, the patients may decide in some cases not to get the tooth removed and maybe just leave it, but they need to know all the details. So you can really show them on the CBCT as well. That's what's happening with your tooth, and you can see this. It's not, gone are the days where the patient used to go get their tooth looked at, and the dentist used to open up the tooth and say it's unrestorable, there's a crack, and then put a temporary in there. The patients used to leave, and they used to say, but my tooth doesn't hurt anymore, and he says it's not restorable. But now we can show them on the screen. We can show them on the CBCT while we're in the surgery, and it's really, really good for the patients to see this. So this tooth isn't really restorable, so the patient's going to get the tooth removed and hopefully move on with replacement. We can't save them all, unfortunately.
Definitely, we cannot save every tooth. So, one of the classic indications for taking a CBCT scan is a previous treatment mishaps. We want to evaluate the previous treatments or even initiated treatments with some accidents. And let me be precise about one single mishap or accident, which is a separated instruments. We discussed a lot in the previous year of Endocast about that nightmare. So, how can CBCT can help the clinician to manage separated instruments, be conservative, or maybe change the treatment plan?
Yeah, this is a very, very interesting one. This patient came to me. They had root canal treatment started by their general dentist. During that procedure, the file was fractured, and the patient's again 50 years old, so many years to chew on this tooth. It's their first molar. I often say to the patients, you know how you say you want to save your front tooth because every patient wants to not have their tooth removed at the front. This is your front tooth at the back of your mouth. This is the front tooth as important as your front tooth for chewing. I say this is the most important tooth for chewing. And if you lose this tooth at age 50, you're going to smash that second molar unless you have an implant, but the implant will be definitely lost in your lifetime as well. So this is a big, big problem. So I look at this patient and go, there's no way we would want extraction of this tooth. There is one thing that I can see about this before. Obviously, the fractured instrument is pretty obvious, and the apical diseases are very obvious. But look at the conservative restoration on this tooth done by the dentist. Whoever did that was thinking smart, and they were very, very minimally invasive with this restoration. There's good pericervical dentine, and so this patient, if we can manage to clean out the root canals, is a good has a good chance of keeping this tooth for a long time, and that's what we want in a 50-year-old patient. So basically, if we go to the CBCT, we're going to look at whether the canals join and whether there was any canals not located during the treatment. And there we go. There's the distolingual root canal of the first molar. And if you look at the instrument in the mesiolingual canal, you'll see further down on the axial slice, and now it joins. So now we're in a situation we can say to the patient, this root canal where the fractured instrument is located is joining the mesiobuccal root canal. The treatment will be successful. I will try and bypass the mesiolingual root file, but it won't really matter because they join. I'll locate the distolingual root canal, which wasn't treated originally, and your tooth has got a really good prognosis. That, coupled with the pericervical dentine, means your tooth is in a good situation. And this is what the patient wanted to hear. In fact, I completed this case, and the patient gave me a massive hug. It was one of those kind of fun ones where the patient hugged me and said, "I'm so happy I came to see you." But that was really nice. But yeah, there's a really good prognosis for this because of the pericervical dentine. You can see that I managed to bypass the file, but obviously the MB root canal was bypassing the mesolingual instrument. And you can see I've had to remove some caries. You can see distally where I've gone across, but there was caries there. So the patient will need a new crown there, but they can probably get some kind of a similar kind of conservative restoration to cover the cusps and stop the fracture of that tooth. And I was really happy with this case because I always feel really, really sorry for the patient when this happens, because they're just looking for a way of keeping their tooth, and we just have to provide that. As in a 50-year-old patient, we just need to keep, try and save this tooth. An implant will not last their entire life.
I have one question for you now. So you have a lot of experience. You are a skilled clinician. You do a lot of endos every day, but still you're saying that even if you're extremely experienced, etc., you still need a CBCT in your daily practice, besides having performed hundreds or thousands of treatment without those scans, because CBCT, I mean, is kind of new as a tool for the clinicians. So like 15 or 20 years ago, we didn't have them. So we should have relied on the, X-rays with the different angulation of the beam, etc. So you see that even if you're skilled and have a lot of experience, you still want to have a CBCT in your practice.
Yeah, it just allows me to basically look through the cases and decide what I want to treat, and also helps the patients make decisions, because the patients are often guided by us. I have to say that I used to say this, and I used to do a lot of podcasts on CBCT, that CBCT is like sat nav. But you only need it for certain cases, because if you're traveling home from work, you don't need sat nav. You know how to get home from work. But then what I found was that there was, as I got using it more and more, I realized that actually it is like sat nav. But if this happened to me once in Australia, I got in the taxi to go to the airport, which I'm going to go to in a few days, and the taxi driver said, "There's been an accident on the harbour bridge. We cannot go to the harbour bridge. We cannot go to the airport via the harbour bridge that we would normally do. We'll have to take you the old way that used to be a different route." And he goes, "It'll take a long time, but we'll probably make it on time. But if we go to the harbour bridge, we're going to be stuck in traffic, turning around and everything." And so I said, "Fine, you're the expert." And I thought that's a lot like CBCT now. It's like we do know our way home from work, but what if there was an accident that was going to stop us and make us turn around on a busy highway, and that was going to make our journey much, much longer? Then we would have wished we would have known that before we started that journey. And that's what I think of CBCT now. I literally as I started using the unit and scanning, I thought, to know that the patient has a separate MB2 straight away, or maybe has like I said, a ribbon shaped or a figure eight MB2, instead of troughing in places where there's no canal, instead of going, maybe it's here, maybe it's there. You just know this at the start. You know the configuration of the canals, and it just makes life so much easier. It means that you can treat patients more efficiently. Obviously, the patients prefer that. They don't want to sit in the chair for hours. They don't want to come back multiple times for you to look for something that's not there. You can save dentine by not having to trough away looking for something that isn't there. And I find that very, very useful. Yeah, so this is an interesting one. The patient came in. This is a general dentist's radiograph. You can see there's a radiolucency at the apex of the first molar, the distal root, and I'm looking at the tooth, and it responds to testing. And obviously, the dentist has tested the tooth, and it's vital. And they're wondering what to do here. Now, I would say that there are cysts and things like this that can involve the tissues around the tooth and not be from a infected root canal. So that doesn't. So even if the tooth tests vital, it might be something like this. And so CBCT is really handy here just to rule that out. Even if you're thinking, oh yeah, that tests vital, it can't be a root canal problem, and it's not. There are cysts and various problems that can cause radiolucencies in the mandible that aren't just apical periodontitis from an infected root canal. So then we can take the scan and we can see straight away that this is just the architecture of the patient's bone. It's a loose bony architecture. They have this everywhere in many positions. You can see all around little islands. The other thing I say to these patients is please don't ever have your tooth removed because implants here are really difficult as well. So this is just normal anatomy, and it's just confirmed on the CBCT.
Yeah, that's an interesting case. And talking about shady and suspicious things, many colleagues are confused about the vertical root fractures, and they think that they can see the actual vertical root fracture on CBCT. And I always tell them, like the small canal thing that you mentioned before, that you cannot see that unless it is very large. This is due to the inherent limitation in resolutions of CBCT, but of course, CBCT can give us some clues about the presence of a VRF. So, can you tell us how to use CBCT to just predict or say it's more likely to have a VRF in that tooth?
Yeah, so we're looking for those widenings around the root that are abnormal, like an apical foramen, which is at the side of the tooth, is the best way. Or maybe it looks a little bit like a lateral canal, but it's much wider. A lateral canal is more like an island of bone loss in the midroot, whereas with this tooth, you can see there's a broadening of the PDL. The patient, again, they're 84, pain on biting, and you're thinking all of a sudden, but the root canal treatment's done to the apex. So all we're going to do here is when we take the CBCT is look for those areas of bone loss around that look like they're around the root rather than located to a lateral canal, because this tooth again was treated many years ago, and history is so important here. Patient had a root canal treatment many years ago, and why has it been okay for many years and it isn't now? And the answer is because it's cracked, and you can see this on the slices of the CBCT here. You can see this buffing of the alveolar bone, and you can see there's a broadening of the PDL space all around, and that's just basically a sign of the root fracture. The other thing that CBCT does, which shows really nicely, is that sometimes you'll have apical into middle fractures in teeth, and you'll just look at them and go, oh. There's no cervical bone defect because the cervical part of the tooth hasn't cracked. It's the apical and middle sections. Quite often happens in lower molar teeth with thinned out, inner curves where the root's been thinned out by preparation. Because again, some of our instruments, they tend to be a bit more bigger than we want in those areas, and really those microanatomy, if it gets weakened, then it will fracture through there eventually. So yeah, this patient had a vertical root fracture. Opinion for replacement recommended. They're in their 80s, so um, they might go for an implant or maybe just accepting the gap. But at least they know what's going on straight away. And the other thing the CBCT does for us is it's very handy for just saying to the patient, look, you could have an implant here, and you've got good bone, or you haven't got good bone. This is my favorite slide for talking about this tools and experience. So the reason why this cricket player is on the slide is this is if you play, maybe you don't know much about cricket, but maybe you follow it. So this guy here is called Lance Cairns. It was a sort of childhood experience that I had with this guy. So he's a lower order, so he's not a higher order batsman. He's a bowler with ability to smash the ball everywhere. New Zealand, which is the country that I was born in, obviously, was playing Australia, which is the country that I live in. Australia were a much better team, and they're playing in the final series that they had on. And New Zealand were not quite as good as good a team in those days, and they were losing badly, New Zealand. And this guy came out. He came out lower in the order, and he was in the freezing works, sort of farm, brought up on a farm, etc., in New Zealand, and he had this bat which had no shoulders, so it looked like a club. And he literally decided that he was going to just smash Australia all around the park just for a bit of fun because we'd basically lost. And he came out with this club, this bat, which looked literally like a club. And he smashed some of the best bowlers in the world all over the ground, including a one-armed six. And so after that match, even though New Zealand lost and everything, everyone was going on about this bat. And every single kid went out and bought that bat and then tried to smash everyone around and couldn't do it because they had the bat, but they weren't Lance Cairns. Uh, it's the same for using CBCT. You have the tool, but you need to know how to use it. It's the same for the microscope. You need to know how to use it. You, it's good to have the tools for sure, but if you don't know how to use it in the right way, you won't get the maximum advantages out of that tool that you have. So it's all about improving your knowledge, and we're always learning in endo. We're always learning. I'm learning every day. I'm sure everyone who's listening, and I'm sure you guys are learning every day on how to use the tools and thinking all the time, like, what can I use this machine for? So this is my favorite slide for showing you can have the tools, but you need to be that player to use it in that way.
Well, I like that take-home message from you about tools and experience. So thank you very much for sharing your knowledge, expertise in a very simple way, and this is very important. And thank you for being with us over 2 episodes. Thank you for your time. I think all of our colleagues will be happy to watch this one. This is very important.
Yeah, exactly. And thanks again, even from my side, Omar, for finding time to join us and to share your knowledge in today's topic. Thank you very much.
Thanks so much for having me. It was great to see you guys again and share some experiences in endodontics and CBCT.
Thank you. So, guys, stay tuned for the next episode of Endocast. Ciao.
Bye.